Hi, Dr. Chamo.
Hello.
How are you?
Good, good. Sorry, I am a little bit late. I got connection problems, but I am here.
Oh, no worries.
No problem. How are you?
And thank you, Dr. Richard. Thank you to have you here, and we are really looking forward for this class. I think I told you that we have a lot of problem with the bladder cancer, so we are really looking forward for this class.
Absolutely, it's my pleasure and definitely an honor to be invited. So I totally appreciate that. I am going to try to give a nice overview. I know we talked about maybe some tips and tricks surgically. I would love for this to be interactive, so I can learn from you all also. And please stop, ask me questions. If there's anything that you want to dive into deeper, please, by all means, just let me know, and we can pause there and do a deeper dive. But I wanted to talk, obviously, about squamous cell, and I'll talk a little bit about some of the gaps in knowledge with that, and then do a nice overview of bladder cancer as a whole as well. That sounds good. All right, so I think I can get started then, yeah? All right, great. So my name is Rich Matulewicz. I'm a faculty member in the departments of urology and population health at NYU in New York City. It's a distinct honor to be invited to give one of these IVU lectures to our colleagues. Today I'm going to talk about the management of squamous cell carcinoma of the bladder and bladder cancer management as a whole. So I have no conflicts of interest or financial disclosures to discuss with the talk. So in general, the learning objectives for this talk are going to be to review and understand some of the unique aspects of squamous cell carcinoma of the bladder, to review management strategies for bladder cancer as a whole, with a focus on advanced bladder cancer and squamous cell carcinoma, and then to discuss some surgical techniques for radical cystectomy, lymph node dissection, and urinary diversion. So I wanted to start with a case that I actually saw pretty recently, just to highlight that, although we're several thousand miles away from each other, we're really not too dissimilar. This is a young boy who came in who had painless gross hematuria. We got an ultrasound, and he had this vascular mass in his bladder. And this young man was actually, his parents were from the Ivory Coast of Africa, and although he had not been there, he did live with them, and they would go back and forth over the last few years, and most recently were there about 5 or 6 years ago. So we scoped him after seeing this mass in the bladder, and we saw several of these little bleeding tumors in the bladder, and biopsied them, and they actually came back, fortunately for him, not bladder cancer, but this was schistosomiasis, which I know you all are quite familiar with dealing with. So although we're quite separated from a distance perspective, we do get our share of these as well. So just talking about bladder cancer epidemiology as a whole in the United States, there's about 80,000 new cases per year, and unfortunately about 20,000 deaths per year. It's quite common in men. It's the 4th most common cancer, less so in women. But overall, it's about the 6th most common cancer in the United States. And worldwide, it's pretty similar, being the 10th most common worldwide, with another male predilection, 6th most common in men, 17th in women. And there's over 500,000 new cases each year of bladder cancer, which the vast majority of these are urothelial carcinoma, but certainly there are differences in the presentation based on endemic areas of schistosomiasis and other exposures. So just to kind of set the stage and review the staging of bladder cancer, we have the bladder over here on the left. You can see that non-muscle invasive bladder cancer involves TIS, TA, and T1 disease, which is not yet invaded into the muscular layer of the bladder. And then you have T2 disease and beyond, which has various invasion into and through the muscle layers of the bladder, including into the perivesical fat, which is T3A and B disease, whether it's microscopic or macroscopic, and then T4 disease with invasion into adjacent organs, including the prostate. And I think it's important to understand also that for staging, a critical component of this is nodal involvement. The staging for lymph nodes in bladder cancer are essentially, if there's a single node, you're PT1, or multiple nodes, PT2, but if you're in the true pelvis. So this is below the bifurcation of the common iliacs. And then if you get nodal lymphadenopathy up below into the common iliacs, that's P3. And anything in the retroperitoneum or more above the iliacs is actually metastatic disease, no longer regional lymph node disease. So when we're talking about the diagnostic evaluation for bladder cancer, as we all know, this sort of ends and begins with cystoscopy, in addition to imaging, which I'll talk about in a second. And the standard, and still what we're using today here as well, is white light cystoscopy. And there is a role, an emerging role of enhanced cystoscopy with things like fluorescence and blue light, which is a chemical called Cysview that PhotoCure has made that does potentially help increase the detection rate of things like CIS or flat papillary tumors. We also have narrowband imaging, which is another sort of emerging technology that helps us see some of these tumors that we may not see as clearly with white light cystoscopy. But the thing I really want to focus on here is actually clinical staging. And this is something that, although I am still on the earlier end of my career here, it's something that has certainly been taught to me from many of the masters that I've learned from at Memorial Sloan Kettering, like Dr. Harry Herr and Bernie Bachner, about the importance of doing an exam under anesthesia. And these two pictures here, I think, highlight this imaging perfectly, because the photo on the left, I think you can pretty clearly see that there's tumor outside of the bladder invading into the prostate and some of the adjacent pelvic floor potentially. Whereas on the right, you see what looks to be like a pretty normal bladder, although there's certainly a little thickening and a little enhancement that you would expect with any sort of bladder cancer. It does not really appear terribly advanced. However, both of these cases, I will tell you, were completely fixed on the exam under anesthesia with the inability to move the organs on the pelvis, indicating pretty significant T4 disease. So I most certainly do think at the time of TURBT and cystoscopy, doing a good exam under anesthesia can help inform your operative approach. And as I mentioned, accurate staging is really, really important, because if you don't really know where the patient is, it's really difficult to plan your treatment strategy and also to tell them and counsel them on what their options are and what their prognosis may be. And I think, the clinical staging, as I mentioned, as important as it is, it does not always match up with pathologic staging, that is when the bladder comes out. So the clinical staging in some of these historical series only matched about 50% of the time once the bladder was actually out, with about a third of these being understaged by TUR and exam, and about 40% then being downstaged or overstaged at the time of TUR. So these are patients that may have had T3 disease during TUR, but then the bladder comes out, it's only T1. And that could, of course, be because a lot of that disease has been removed. But on the other hand, in the patients who are understaged, that's the inability of both imaging and the TUR to really accurately tell how advanced the tumor is. Similarly, in some of the MD Anderson perioperative chemotherapy trials, only about 40% of patients actually matched. So I think one way of helping out the situation and getting even more information is to perform a re-TURBT. So this is a second transurethral resection of the bladder tumor after the first. If there's any question that there's residual disease, or really what I do in my practice is any evidence of high-grade disease, even TA in some cases. And the reason for this, as Dr. Hirsch showed years ago, is that about 3/4 had residual cancer at the time of their second TURBT, and about a third were upstaged from non-muscle invasive bladder cancer to muscle invasive bladder cancer, which obviously changes their treatment strategy considerably. And this is especially important if there's no muscularis propria, if there's no muscle layer present and sampled on that first TURBT. So if that was the case, then almost 50% of these patients were upstaged. So I really think that TURBT and then repeat TURBT can certainly change your treatment decisions and improve outcomes in non-muscle invasive and muscle invasive bladder cancer. And again, the importance of the exam under anesthesia for completeness of staging cannot be overstated. So imaging, as I said, is the other component to staging. I think that in patients who are smokers or have other risk factors, it's a very good idea to get a CT scan of the chest rather than just a simple chest x-ray. I don't want to belabor this too much, but this is a space that I think will be evolving in the future. I think the use of MRI potentially and other types of scoring systems for imaging, similar to what we do in prostate cancer, may be coming down the pipeline, as are other molecular imaging studies like PET scans that may be helpful to figuring out if equivocal nodes on normal conventional imaging are positive. So to talk, take a step back and talk a little bit about what Dr. Chama wanted me to speak about today is squamous cell carcinoma. And I think the best way of kind of dividing up the pure urothelial carcinoma and then some of those variants is this way, where you have variants that are predominantly urothelial carcinoma, so urothelial carcinoma with squamous differentiation, the micropapillary disease, microcystic disease, sarcomatoid, or even plasmacytoid variants. And then you have pure variants where there's no evidence of urothelial carcinoma. And this is where you get into your small cells, your neuroendocrine type, pure squamous cell carcinoma, which I'll talk about a little bit more, and then the adenocarcinomas and urachal carcinomas. And this is really kind of where things, are drawn down the middle because of how they're managed from both a chemotherapy perspective and sometimes even surgically. So in pure squamous cell carcinoma, in the United States, this is really only about 5% of patients. And there's really a few reasons for that. One is that the schistosomiasis, there's very little endemic presence of the worm in the United States. However, we do see pure squamous cell carcinoma in patients who have chronic indwelling Foley catheters and patients who may have other chronic irritants, even something like HPV infection. However, probably in areas where you all are working, it can be seen at up to 30 or even 50% of patients have pure squamous cell carcinoma as opposed to urothelial carcinoma. And I think the real difference here is that, unfortunately, this tends to be a much more aggressive cancer. And whereas patients would only present about 20 to 30% of the time with urothelial carcinoma having muscle invasion at presentation, in pure squamous cell carcinoma, patients are presenting almost 70% of the time with muscle invasion. So this is far more advanced disease. The other real hallmark of pure squamous cell carcinoma is local regional failure, meaning that even after the bladder is removed and the lymph nodes are taken out, the patients tend to recur locally just because of how, this type of cancer tends to seed and grow and recur, whereas only about 10% of patients who recur have widespread metastases, which is certainly different than what we see with urothelial carcinoma. So what this really means is that local control of disease with removal of the bladder and then lymph node dissection and control in the pelvis is of the utmost importance, making surgery so much more important in this particular disease process than even in urothelial carcinoma, where it's still incredibly important. So to kind of, I don't want to belabor this either because you all know this a lot better than I do, but a lot of the the schistosomiasis infections are caused by several species of the trematode genus schistosoma, and these are endemic to certain areas of the waterborne disease, usually acquired by direct contact with fresh water where these snails and worms live. And unfortunately, in areas where this is endemic, nearly everyone is exposed to this. And this is just an example of kind of the lifestyle, or the life cycle rather, of the snail and the worm, and how it does ultimately get into the human host, which can also affect the GI system. So one of the things that I kind of learned throughout my most recent case with this young patient that had come in, that eosinophilia in the blood test is actually a fairly specific, rather sensitive means of understanding that someone could have schistosomiasis, especially in the acute phase. And patients who are left to have chronic blood loss from both GI and GU losses can present with anemia, but largely hematuria, and being exposed to this should really raise the flag of someone potentially having this. So going back to just general concepts in bladder cancer, I think anytime someone comes in and is diagnosed with bladder cancer, specifically muscle invasive bladder cancer or more advanced cancer, I think it really should elicit a conversation with the patient and the patient's family to understand really what are the goals of care. Is this someone who's very elderly and frail? Is this someone who has a very long life expectancy and is young and fairly active still? What are their real goals in whether it's disease control or longevity, and whether there are other factors to take into account, such as the patient's nutrition status, whether they have any sort of significant protein malnutrition, and whether they're frail. So I think really getting an idea and using all of the tools available to us, whether it's nomograms or frailty indexes or any of the kind of tools that are available on the internet to understand this person's functional status limitations and comorbidities, will be very helpful to kind of frame the conversation and do a good have a good discussion with the patient about what to expect during and after surgery. I think teaching is critically important as well. Anytime someone has their bladder removed, and certainly with a urinary diversion, this is a very, very large change to their quality of life and just their entire approach to taking care of themselves. So I think really starting this process even long before surgery begins is very important, especially if you're talking about someone who's going to need an ostomy or a neobladder, where they're going to have to catheterize potentially. And although surgery is certainly the first and best option for patients with squamous cell carcinoma that's still somewhat localized, there are other options, including radiation and chemotherapy and radiation combinations, that should be considered in patients who have bladder cancer. And I think as we move forward and we learn more about all of these things, a multidisciplinary approach is going to be very important. And really, ultimately, what you want to do when you're treating this patient is to balance the treatment and quality of life side effects of all of these things with the goals of cure. I think just going on my soapbox here, because this is something that I study, and the importance of smoking cessation around the time of a bladder cancer diagnosis. Although bladder cancer, the urothelial carcinoma type, is certainly much more related to smoking cessation than squamous cell carcinoma, I think there's very good data to show that patients who quit smoking will have far better outcomes, and that's not only perioperative outcomes, but it's also their response to chemotherapy, their recovery, their quality of life. And I think it's a good idea to really try to help the patient quit smoking as they're going to go through their cancer therapy. So when you're talking to a patient and trying to figure out what type of urinary diversion is best for this patient, I think it's important to understand that each urinary diversion has its own unique challenges, both surgically and for the patient. And then there are certain quality of life implications that go along with each of them, whether it's changing or wearing an ostomy, whether it's the possibility of having urinary retention with a neobladder because of strictures or anything like that. And if you do have, the benefit of having stoma nurses and other people in your practice who are experts in helping patients deal with these lifestyle changes, I think it's important to have those patients engage with them very early on, because as I said, the more teaching, the better. There are some publicly available resources and decision aids that can help patients, even when they're in your office, try to figure out what their goals are and what they're capable of. Those are available through the Bladder Cancer Advocacy Network, through this link on the Action Bladder Cancer UK's website, and then some publications also that have tried to look at some decision aids to help patients make these decisions. But I think very importantly, even if your plan A is to do a continent diversion like a neobladder or a pouch, I think there are certain situations that you'll get into and that you'll find that you will not be able to ultimately do that, whether it's because the patient has CIS at their bladder neck or whether it's because the bowel is not friendly to do the situation. I think it's always important to understand and know that you have a plan A, a B, and sometimes even C. As you can see here, depending on the type of urinary diversion, there are certainly variations in also the complications and the types of complications. So I think when discussing these options with patients, they should know that certain situations where they have a ileal conduit may have benefits in some ways, but there also may be drawbacks in others. So just general treatment considerations. In 2021 here, I do think that neoadjuvant chemotherapy for bladder cancer is a standard of care. Now, the caveat to that is that there's been very little study in pure squamous cell carcinoma using neoadjuvant chemotherapy. Most of these studies have excluded patients with pure variant histology, so they really only have been studied in patients with urothelial carcinoma of the bladder, some with some histological variations, but certainly none that have been largely studied with squamous cell carcinoma. But there's a lot of evidence that does support the use of neoadjuvant chemotherapy, and meta-analyses would suggest actually a hazard a little bit below 0.9 for overall survival in using neoadjuvant chemotherapy. So this is something that in patients who are fit, we do suggest. However, the unfortunate situation is that because of patients' age, some of their comorbidities, and their renal function, only about 50 to 60% of patients who are eligible for neoadjuvant chemotherapy are actually able to get it because they are quote unquote fit for it. So this is certainly not available to everyone. And I do think that the data would suggest that in patients who are downstaged and patients who are good responders to neoadjuvant chemotherapy that do not have muscle-invasive bladder cancer at the time of their cystectomy have far superior outcomes. And this is certainly an area where this finding was further explored and found to be related to some of the specific mutations inherent in these patients' bladder cancer that made them cisplatin more sensitive, which ultimately allowed them to see the survival benefit because of the chemotherapy. However, the flip side of that coin is patients without that do not necessarily see the benefits of cisplatin-based chemotherapy. So this may be a point where if we know those patients do not have those types of mutations, then we move directly towards surgery, or if they have more advanced disease, that perhaps they get tried on an immunotherapy. So looking at outcomes in pure squamous cell carcinoma, there's really been one report out of Memorial Sloan Kettering of 20 patients looking at systemic therapy in variant histology, and really only 8 of these had squamous cell carcinoma of the bladder. And as you can see, that patients who ultimately received more intensive therapy with radiation, surgery, and sometimes chemotherapy as well did do better. And the thing I want to draw your attention to here is that although these numbers are very small, there is a prolonged, survival in patients who are able to basically have their cancer treated intensively and early on. So you can expect to see almost 40% of these people have long-term positive outcomes. So I think it's worth mentioning that although we talked a lot about just cisplatin-based chemotherapy as a neoadjuvant, there are certainly lots of trials and lots of novel agents being studied in the neoadjuvant space that I think in 10 or 15 years, potentially, some of these may be new standards of care. So to get into some of the meat of the surgical considerations and technique of radical cystectomy and sort of how I like to do things, and how I was taught to do things, just some general considerations first. And the first one is that timing is important. I certainly think that although we cannot necessarily control when patients present to us at what stage of disease they do, I do think that from the time of diagnosis to cystectomy has been shown time and time again to be very important, especially in something that is very aggressive and locally aggressive like squamous cell carcinoma of the bladder. And as I said, variant histology matters. So patients, you're going to have to change your approach based on what type of histology the patient has. If they do have more of a traditional urothelial carcinoma type of cancer, it certainly will fit more the usual mold where you're going to want to move from neoadjuvant chemo to surgery if they want. However, in others with more aggressive variant histology, sometimes moving directly towards cystectomy is the right option. The alternative to that, too, is in patients who have a small cell. These tend to be very, very early metastatic. So there are situations where patients will first get systemic chemotherapy, and then their bladders will be assessed down the road depending on how well they respond, just because there's such a predilection for early and distant metastases in that type of cancers. I think when you're starting a bladder cancer program, it's very important to identify what outcomes are important to you and the patients and start to track them, because I really do believe this phrase that you can improve upon what you do not measure. So you're going to want to see how your blood loss is, how long these operations are taking, what types of diversions you're doing, how often patients need to return for second surgeries, how long patients are staying before they're able to go home and be independent again. And I think by tracking these things, you can try to figure out, okay, well, patients are doing great while they're in the operating room, but maybe they're a little bit sluggish to go home. Maybe we need to get some more intensive treatment when patients are still admitted to the hospital. I think this is the way of really understanding where you can improve on things. And I think volume is certainly king. It's very difficult for anyone to do surgery well if you're not doing it very often. I think that, surgery is certainly a team sport as well, and that the more often you're able to do these procedures with familiar people, the better you're all going to get at them. So I think it's incredibly important to develop the team and have familiarity, and really that's really where you get into a rhythm where you're able to do good surgery. And then really selecting the right treatment for the right patient at the right time goes back to what I was talking about with really understanding what the patient's goals are, and what they can tolerate, and what you think and they think is the right option moving forward. So as I said, time to treatment, quite important. I think this shows the data about how quickly patients should really get to the OR. And usually with a rule of thumb is about 6 weeks if the patient's getting neoadjuvant chemotherapy, about 6 weeks after they've completed chemo, and then if there's no neoadjuvant chemo, about 1 month from diagnosis. The other thing that's critically important are margins, especially with squamous cell carcinoma. There are certain situations where you are never going to get clear margins in someone who has very, very advanced disease, and there may be a role for palliative operation in that situation, and that's why you would do it. But obviously the goal of any surgery is to completely remove all disease, and that certainly should be the goal in managing bladder cancer, of course. Because there really is no adjuvant chemotherapy, no adjuvant radiation therapy that can salvage inadequate surgery. So it's critically important to get negative margins to remove all visible disease. And it's incredibly important also to understand if that is a possibility before you undertake the operation, because there are certain situations where you may actually be doing the patient more harm by operating on them without actually helping them from a cancer perspective. I think in considerations for male and female cystectomy, there are certainly differences. For men and for women, it's important to discuss both sexual and urinary functions that are going to be present before the surgery, and then obviously the change after surgery. I think for women, especially women of younger age, that there is a potential benefit in some situations to performing reproductive organ sparing radical cystectomy. I think this helps improve continence, helps preserve sexual function better. And in well-selected cases, there is no change to oncologic outcomes. Obviously, if someone has a very large invasive posterior tumor where you think this could be invading into the anterior vaginal wall, it is probably not smart to go about this type of procedure. But in young patients who have amenable tumors and are motivated to preserve their urinary and sexual function, I think it's a good idea. Especially in female patients who you're going to consider doing a neobladder on, there is a very high risk of hypercontinence because of how the pelvic floor changes and how the urethra changes. So counseling patients on the possible need to catheterize long-term is important here. Performing a nerve-sparing operation to preserve male sexual function can be performed similar to a prostatectomy. And for the most part, unless the patient has T4 disease or really something into the prostate itself, most of the time this will not really hurt your oncologic outcomes. So just wanted to go through a few steps, and these images are borrowed from Campbell's and the USC surgical atlas, but I certainly think that this mirrors pretty well my approach, and I tend to try to mirror the way I do these cases, the way Dr. Bernie Bachner has done them, who I think is absolutely fantastic bladder cancer doctor and certainly one of the most impressive surgeons I've ever seen operate. So I try to do everything as close to possible as he does, but I'm sure I still fall short here. But my approach here is essentially starting from the beginning, getting the patient in a little bit of flex, which will put a little bit of tension on the abdominal wall. I do like to frog leg the patient, or in female patients, I will put them in a lithotomy position to get access to the vagina and to remove the urethra, especially when doing an ileal conduit. I like to begin the operation. I do tend to stay at or around the umbilicus when making the incision. This probably is a little bit longer of an incision than I normally do make, but I will enter the peritoneal cavity. I will find the urachus, mobilize the lateral flaps here in order to get the urachus up and get the bladder up and out of the way. Obviously, the catheter goes in first, and you want to avoid any sort of urinary spillage as much as possible. I think it's critically important to really make certain that you're able to take the bladder out before taking the ureters and ligating anything in the pelvis. So I really do tend to start with good bowel packing and mobilization, and then even we'll begin with the lymph node dissection in order to make sure the bladder is actually able to be removed. And I think this is really the part where I was starting out. That was the most important for me, was really understanding just how important mobilization and setup for this case is. And I think the best means of going about doing this is to open things up in this fashion, where you're looking at this as if it's a triangle along the root of the mesentery all the way up into where the third and fourth segments of the duodenum are, and then along the white line of Tolt, where you're able to actually get the cecum up and out of the way, and you're exposing essentially the entire retroperitoneum up to almost the midline. This will allow you to see the ureter, which you can see running here, and this will allow you to get good exposure to the right common iliac, which is where you're going to really want to start at minimum your lymph node dissection. This is accomplished similarly on the left side, where you're mobilizing the sigmoid colon off the left side wall, and you're actually lifting the sigmoid mesentery off the sacrum, which will act in two ways. Number one, it will allow you to mobilize the sigmoid and move it back and forth in order to get to your iliac and help facilitate your lymph node dissection. And it will also actually open up that space where you're going to pass the left-sided ureter underneath for any sort of urinary diversion. So this is where, once you have all of that exposed and packed, I like to pack it with several moist laps and then a rolled towel, which is pushed up. Sometimes I'll even take the omentum and put it over and around to almost act like a basket in order to keep all of that small bowel from falling into the pelvis. You can use a little bit of Trendelenburg with the table down, and really you want to get all this bowel out of the way. I think the operation becomes 100 times easier if everything is well mobilized and packed away. And for me, it was really seeing the setup the way I had seen it many times over through my training, and with all the great surgeons that I worked with. They had this ability to beautifully set up the case, which just made it go that much smoother. And I think once I understood the importance of that, it really helped let me take the next step with my surgery. And here, what this is really demonstrating is the beginnings of the lymph node dissection using the split and roll technique, where you're essentially cutting along the vessels and allowing the tissue to kind of fall apart and to dissect it off both sharply with cautery and with clips. And this demonstrates part of the technique of passing a sponge behind the vessels once they are mobilized, in order to really get even any speck of fat out and potential lymph tissue that's left behind. And this really shows, and I'll show some more pictures in the subsequent slides here, but this really shows the extent of the dissection with the generofemoral nerve on the psoas muscle here, with the external iliac vessels going down into the obturator fossa here. The goal is really to completely clean this out and skeletonize this. And I'll get back to the lymph node dissection in a second, but once this is all completed, and I think that the bladder is able to be removed, the ureters are then ligated, similar to as it's shown here. I tend to ligate them as close to the bladder as I safely can to make sure that there's no urine coming out. After I ligate them, I will usually double clip or tie down the ureter stump with a silk tie. What's pictured here is the incision of the pouch, and to start to get into Denonvier's fascia. I think this is an important step too, that you set up with the beginnings of your lymph node dissection, because once you've taken the peritoneal reflection on both sides, you really just have this little smiley face left here, which certainly helps facilitate where to make that incision. Otherwise, there's a lot of guessing sometimes. I think if you haven't done that, and you really run the risk of getting into that posterior space in the wrong spot. And then from here, once that posterior pouch is opened up, you can see the sagittal view here. it's really, hopefully, more of a blunt dissection down the posterior aspect of the bladder, the seminal vesicles, and really in patients who do not have a large tumor in the back or haven't had radiation or any other prior surgery, a lot of times you can actually completely bluntly mobilize this. And obviously you don't want to do that if there's any sort of adhesions or prior surgery or anything that would obliterate these planes, where you would have to turn to a more sharp dissection, where it's a lot of lifting and cutting in the areas that are adhered. And then once you have the bladder up, you've essentially then left with both the posterior and then the lateral pedicles that you can take with either a surgical device or with suture. This is one way of taking the dorsal venous complex. This is similar to an open radical prostatectomy, where you're going to isolate the DVC, suture ligate it, and then essentially complete the apical dissection. And this last little picture here that I put up is essentially the means of dealing with the vaginal cuff. I think if you are going to remove that anterior vaginal wall or even part of it, you know, putting these stay sutures in early on to facilitate some of the closure is an important consideration as well. And this is an example too. Once that vaginal cuff is removed, you have your stay stitches in, and then you're closing the cuff in a running fashion. And you can see this is a consideration of someone having a neobladder because these urethral stitches were pre-placed. And this is an important thing to consider as well, that if you are going to do a neobladder, you do not want to have really overlapping suture lines. Excuse me. So placing the omentum as an interposition in the pelvis helps prevent the risk of fistulization there. So as I started to talk about the importance of lymphadenectomy, I think it's very highly debated, but in someone who has a squamous cell carcinoma, for surgeons that manage a lot of squamous cell carcinoma, I think this is even more important than in urothelial carcinoma, just because of that very high predilection of local regional failure, especially failure in the pelvis, and what that could mean. So in general, though, bladder cancer has very much a Halstedian spread, meaning that it's going to go from your local tumor to more of the sentinel lymph nodes and then regional lymph nodes without just skipping to much more distant lymph nodes or distant metastases. And some very nicely done anatomical studies have shown that skip lesions are actually pretty rare, about less than 10% of the time. I do think that your lymph node yield, meaning how many lymph nodes are removed, is a reflection of the quality of your surgery and the extent of your surgery. But with that said, it's important to really partner with our pathology colleagues to make sure they understand the importance of counting the lymph nodes. And really, the thing that I've seen benefit from is sending, rather than sending just left and right lymph nodes, I will send the specific regions separately. And that in and of itself has improved my lymph node yield, because I think the pathologists know it's that much more important to sift through them. So these are the general regions of the lymph nodes. These are some of the ways I will send the packets. This is all variable, though, because there are certain techniques, especially when you're sweeping some of the fat lateral to the bladder in, that you may actually take some of these lymph nodes with the actual bladder specimen. So these are just sort of general ideas. It's certainly reasonable to send groups of these together. Again, this is if you're really doing a very large lymph node dissection. This is an example of some of the retroperitoneal lymph nodes as well. But for the most part, I think even an extended lymph node dissection will really stop at the IMA, where the IMA crosses on the aorta. This is data from Dr. Herr from several years ago, basically showing that there is a recurrence benefit in patients who have a larger lymph node yield. So the thought here is that, even if you do or do not have disease, that removing more lymph nodes may actually help because of this micrometastatic spread, this below clinically detectable presence of metastases that you've then removed. So as I said, there's been some nice lymph node mapping studies that have been done. These really show that a limited pelvic lymph node dissection, so similar to what you would consider a prostate, really only remove about 50% of all the primary lymphatic landing sites. So by doing just the prosthetic, similar prosthetic lymph node dissection in the pelvis, where you're not really getting into the internal iliac or those deep fossa marseille, or doing some of the more common iliac or even higher lymph nodes, you're really missing about 50% of the primary lymphatic landing sites. So if you really want to remove about 90% or more of where cancer can reasonably land, it's important to include the lymph nodes lateral, medial to the internal iliac vessels, and then the common iliac up to where the ureters cross the common iliac and sometimes beyond. And this is just another example, I think, of some of the pelvic sidewall anatomy and understanding the extent of the pelvic lymph node dissection, and really what I would consider what a quality lymph node dissection looks like, where you have completely skeletonized vessels. And this is the area where I think is certainly the space to be most careful, where you have the common iliac veins crossing under your common iliac arteries. This is sometimes an area where there's a lot of very small perforating vessels to be very careful with clipping and cutting. So, as I mentioned, this is still sort of up for debate about the merits and the drawbacks to doing an extended lymph node dissection. And this is a recent study that came out in European Urology that claims to show that there is no benefit to an extended pelvic lymph node dissection. But I think there were a lot of methodologic and statistical concerns with this. But it's worth acknowledging because it's a nicely done attempt at a surgical randomized trial. But I would say that this did not change my practice. I still do perform an extended lymph node dissection in most cases. So just to touch briefly, because I do want to leave some time for questions about some bowel management principles, I think having a tension-free anastomosis with anything is incredibly important. Making sure that your bowel and your ureters both have good blood supply prior to anastomosis, and then preventing bowel contents from spilling as best as you can when opposing bowel, doing a serosal to serosal opposition, and then preventing twisting of the mesentery are incredibly important. I do a Bricker type anastomosis, which is two separate end to side anastomoses of the ureter into the conduit. There are some patients, some surgeons who do a Wallace, which is integrating both ureteral anastomoses into one implant into the colon or bowel segment. I think in cancer cases, there's a risk of seeding the contralateral tract if there is a recurrence, so I tend not to do that. And I do think that it's something that I'm just not as familiar with. So I think it's always good to stick with what you're familiar with. I do try to minimize handling of the ureter, so I try to do a no-touch technique. I use a holding stitch that I put on very early on after taking the ureter, which allows me to manipulate it without grabbing it with any of the pickups. I use an interrupted forovicral stitch on a cutting needle to do my anastomosis, and then I always place stents as well. I don't want to spend too much time on this. This is basically just some of the data supporting trimodal therapy or chemoradiation therapy. I don't think this applies really very much specifically for squamous cell carcinoma, but I do think for urothelial carcinoma that is localized, that does not have hydronephrosis, this is a potentially good option for patients who are not willing to have a cystectomy. But I think that there are certainly drawbacks to this this approach that we can talk about if that is something we want to talk about. But just to kind of highlight the major takeaways is that radiation is good to treat the whole bladder and pelvis in regular urothelial carcinoma. It does control early perivesical disease, can stabilize lymph node metastases, and for the most part, it will preserve a patient's bladder function. It certainly won't make it better. It will most certainly improve local control over no treatment, but there is a non-zero chance of causing secondary tumors in the GI system or in the pelvis. Radiation is not good at preventing new tumors from forming, so the only real way of doing that is to remove the bladder. It does not treat CIS or mucosal disease effectively, It does not treat bulky disease very well. It's largely unstudied in variant histology. So just wanted to talk a little bit about how we care for our patients after the operation, because I do think this has kind of helped improved outcomes, whether it's because of just our more attention to detail in this situation, or it's because any of these things actually work separately is certainly up for debate. But I think the real three means of approaching an enhanced recovery after surgery, or an ERAS protocol, are the pre-op optimization, the intra-op management, and then some of the post-op things we do. I think the post-op stuff is certainly the most important. We try to get patients up and out of bed early. We try to get them out of the chair and hopefully walking on the night of surgery. We try to minimize narcotics to prevent ileus. And I do believe in early feeding in patients who I think are good candidates for it. So this is not the person who's belching and burping on post-op day one. This is the person who's up and out of bed. And I certainly think prophylaxis for DVTs and pulmonary embolism should be given while the person is in the hospital, and then extended actually up to 30 days after the surgery. There are certain things that I think are thought to help. One of them is this medication called alvimipam, which is a peripheral acting opioid antagonist that essentially prevents the pain medication we give patients from causing an ileus. I think this has been studied and has been shown in randomized trials to work. However, it is an expensive medication, and some of the hospitals in the United States here don't even cover it. So it's something we've had to deal with off and on about whether it's even available. I think in patients who have really adverse pathologic features at the time of cystectomy, it's important to consider adjuvant chemotherapy. I think in patients who have squamous cell carcinoma that have very advanced disease and have positive margins, this is even the group of patients to consider adjuvant radiation in. So I think really understanding once the bladder is out that the person may be a candidate for adjuvant treatment afterwards is important. And a meta-analysis of adjuvant chemotherapy did show about a 25% mortality reduction compared to observation alone. And this is something that I do offer to patients at high risk for disease recurrence. So some other things to keep in mind: good surveillance after surgery and once the person's discharged are important to find early recurrences. Doing cytologies in the urine and urethral washings is something I do believe in, because I do think we find a lot more urethral recurrences than some other folks are just because we're looking for it more often. And then really just observing the patient's electrolyte changes after you basically take their bowel and turn it into their urinary tract. So in the terminal ileum, you need to monitor B12 function. In patients who have conduits or pouches looking for acidosis or deteriorating renal function, and involving some of our internal medicine or nephrology colleagues if necessary to help manage these things. So I think in the future, we're going to be using genetic information to make decisions more to see who's going to most benefit from the treatment we give them. I think the increase in novel targeted systemic agents will change things a little bit. And I think that our entire approach to bladder cancer will be certainly evolving over the next 5 to 10 years based on all these information. So I think there's a lot to be excited about in the treatment of bladder cancer. I want to thank you all again for inviting me. Hopefully this was informative, and I'd love to chat about anything necessary or any questions you may have. So thank you very much. Dr. Chalmers, did you want to discuss a case or anything like that?
Oh, Dr. Richard, first of all, thank you. Thank you for your time. Thank you for the great relation that you provide us today. And like I said in my last email, we'll not be able to present any clinical case once we didn't have any patient that we was able to do the surgery.
Gotcha.
So I will invite my colleagues, and if anyone have any question, that this is the time for that. So anyone has a question for Dr. Richard? So maybe I will start, Dr. Richard. You can hear me?
Sure. Yeah.
Yeah. I think I'll give you a picture that the situation that we are facing here. Like I said before in my email, our bladder cancer is almost all of them linked with the cystosomias, the squamous cell bladder cancer. And we have a patient with really young age. I think now we have at our service a young girl with the 16, I think with the 16 years old, just to give a picture that patient that we have. And we have a big problem with the timing. I mean, to do diagnose, we usually to take the patient to make the cystoscopy and biopsy and get the results. We lose in this process about 1 month. I would like to hear from you what you think about this length of time to wait just for the biopsy, and if what is the implication in the outcome of this disease?
Yeah, I think that time is certainly our enemy with bladder cancer, especially advanced or potentially advanced bladder cancer. So any way of speeding that up would probably help. However, figuring out, I think, where the delays are is probably the most important. Is it that the pathologists are just not familiar and that they're having difficulty making the diagnosis, or is it an operating room availability? Like where do you think the biggest delay is? Because then,
on fact, is the delay is in the whole process. The time that patient come to us, the time that we can organize to take to the OR, the time that we'll wait for the pathology results. So all this process take time. And another issue that I want to bring here is that currently we are not able to do the biopsy using TURB. We are using like I will say cold biopsy, and the man of this time, and the man of the time that the outcome from this biopsy is just inflammation process is not exactly the bladder cancer. So you will advise when you have a clear cystoscopy showing that you have a bladder cancer, but the pathology is negative. You will advise for radical surgery in this case.
it's a tough call. I mean, I think the alternative is, I think so this is a situation where you see a tumor, but the biopsy says no tumor, and it's just inflammation?
Yes.
Yeah, that's tough because, you know, I think a lot of, you know, diagnoses can be made visually, but because there's so much difference in how non-muscle invasive cancer is managed compared to muscle invasive cancer, I think that really establishing that diagnosis is very important. I think if you have a solitary tumor in a favorable location, you know, even making a small cystotomy and taking the tumor out open may be, you know, an option, provided there's no spillage of urine. I mean, that's a very kind of difficult situation, I would say. But the biopsy is so important. So I would say maybe getting more tissue than normal and just taking a lot of grabs, and it's tough.
Okay. Thank you.
So is there no TUR equipment, or is the
In fact, we have the equipment, but for now we are not using because we are lack from some device that are important for to use it. So for now,
like the energy?
yeah, the cable for the energy, the lens, the stabilizer, and some kind of device that we are lack of. So this is our challenge. I can tell you, for example, right now we have 4 patients in our service that they are in our ward, and we don't know what to do. In fact, we have, for example, right now we have MRI for these patients. We are already done, but we are afraid to do the biopsy because we know what will be the result. The result will be inflammation because we are not able to pick the right tissue for diagnosis. So yeah, that's
But
really.
But the MRI shows a clear tumor?
Yes, in some kinds of them, yes. The MRI show it, and we already saw the tumor during the cystoscopy. So
yeah,
we are
I mean,
sure that.
Well, you know, if the MRI shows invasion and it visually looks like a bladder tumor, you know, I think that it's reasonable to operate. That's the only problem is if that, you know, turns out to not be cancer, that's a big problem. But I think based on if it looks like an invasive tumor on MRI and it looks visually like a cystoscopy, I mean, you're probably going to be correct. And then, yeah.
Okay.
Is it possible to do a partial cystectomy? Like if it's one tumor? Because that would be, you know, that would save the patient from having their bladder removed. And then, you know, if it does look like really advanced cancer, you can go back and take the rest of the bladder out.
I think we have done 2 partial tumor. I guess Dr. Mansi is here as well. He can make a comment about that. I think we have done 2, but the big problem is we are not able to do more partial because our tumor they are really big. When the size is big, is sometimes the tumor is in all bladder holes. So it's really difficult to find a patient that we can do a partial. Most of them they got we need to do like say radical.
Yeah, I think if the MRI shows invasion, then I think that's very, very helpful in that situation because you know, a tumor that's invading needs to come out regardless. So.
Okay.
All right. Any other questions or anything I can help with? All right. Well, it was nice talking with you all. And Dr. Chamo, please email me with anything. I'm happy to help and continue this exchange for as long as you'd like.
Yes. Cool.
Any
Thank you very
cases,
much.
pictures, anything, please. I'll be happy to look things over and lend my advice if I can.
Yeah. Yes, yes. Thank you, Dr. Richard. For sure, we'll share with you information. At least for these 4 patients that we have in our service right now, we'll share with you, and maybe we
Sure.
can
Happy.
discuss what will the best plan for this patient.
Yeah, absolutely. That sounds great.
Yeah. And thank you again for your time. Thank you for your class. Thank you for the knowledge that you could share with us today. Thank you a lot.
My pleasure. It was great to meet you all.
Yeah, thank you so much.
No problem. Bye, everybody.